Hi, everyone. My name is Stephanie Suarez Gonzalez. I am the Clinic Partnership Manager for MAVEN Project. Thank you all for joining us today and for our friends at Manat Community Health Center for hosting today's session, Dementia, Evaluation and Treatment by Dr. Richard Mesher. Richard Mesher, MD, retired from general neurology practice after 37 years in practice. For 9 of those years, he was chief of neurology, neurosurgery, and PM&R departments. Dr. Mesher engaged in clinical research, including participating in drug trials for multiple sclerosis. He also had a subspecialty practice in movement disorders, actively participating in a program for deep brain stimulation in Parkinson's disease and other disorders. 6 years leading up to his retirement, Dr. Mesher practiced general neurology at Virginia Mason Medical Center in Seattle, Washington, where he taught internal medicine residents and medical students. He has been a member of the American Academy of Neurology since 1983. And with that, I will pass it off to Dr. Mesher.
Okay, thanks, Stephanie. I appreciate that. I appreciate the opportunity to speak to you today. We're going to talk about the evaluation and treatment of dementia. Disclosures, I have no disclosures of any kind. And you already heard about the CME accreditation that MAVEN provides. So our objectives today are to diagnose, recognize dementia, and make a clinical diagnosis, and then review what testing clinically and also lab testing is appropriate. We're going to focus a lot on Alzheimer's disease because it's the most common cause of dementia in older people. And then I'm going to touch on some new developments in the field of Alzheimer's. One is the medications that are now available to treat Alzheimer's disease and maybe modify the progression of the disease. This is known as anti-amyloid therapy. I'm also going to talk a bit about the new tests that are available for Alzheimer's disease, including blood tests. So before we get into that, I want to review a few things to understand what dementia is and how we recognize and diagnose it. To do that, we have to understand about the cognitive domains, the different parts of cognition. And these include executive function, which is in the frontal areas and elsewhere. Memory functions, forming new memory is in the inner aspects of the temporal lobes, particularly a structure called the hippocampus. Language function, and that's usually in the left hemisphere, sometimes in the right and left-handed people. And then visual spatial tasks, which is more posterior in the occipital and parietal areas. So these are the cognitive domains. This is just a picture to show that there's an inner aspect of the temporal lobe, and this is really important because a lot of the early symptoms of Alzheimer's disease are memory problems, and the memory function forming new memories is in the medial temporal lobes, the hippocampus area. And you can see pathology early on in this part of the brain, as I'll show you, and also see changes on scans. So how do we define dementia? Well, it's defined as an impairment in intellectual function affecting more than one of those cognitive domains that I mentioned. So poor short-term memory alone is not enough to define someone and diagnose someone as having dementia. You have to have more than two domains affected. The cognitive decline has to interfere with their ability to function socially or in their occupation. It represents indeed a decline from previous level of function. It's not a static process, and it's not explained by some intercurrent problems such as delirium or psychosis, or other major psychiatric problems. So this term is out there. You may hear about it, mild cognitive impairment, MCI. Um, and this is defined as cognitive decline, which is abnormal for age and education, but the patient still can function pretty well. Uh, and in Alzheimer's disease, the earliest symptoms are the inability to form new memory. People get forgetful. And when they're tested, they have a memory deficit, but their other cognitive domains are are intact, I should say. And this is what's often referred to as amnestic mild cognitive impairment. And it is really early Alzheimer's disease in most cases. And about 15% per year of people with this problem convert to Alzheimer's disease diagnosis, meaning other cognitive domains begin to show impairment. So there are other dementias other than Alzheimer's disease. As you can see on this pie chart, Alzheimer's disease is the most common. And when you combine it with vascular and a combination of vascular and Alzheimer's, 3/4 of the patients with dementia have those patterns. Um, there are other dementias. There's Lewy body dementia, dementia with Parkinson's, and frontotemporal dementia, as well as vascular dementia. I'm not going to go into much about Lewy body dementia or frontotemporal dementia in this talk, but it is they certainly are uh, out there, and you might encounter people with these diagnoses. So what is Alzheimer's disease? It's the commonest neurodegenerative and dementing illness. As I said, the prevalence is related to age. And it's remarkable that over age 90, 50% of people have Alzheimer's disease. So age is a huge factor. Also, as I mentioned, having mild cognitive impairment, memory problems really put you at risk for turning into Alzheimer's disease. There is this allele, ApoE allele, that if you have a certain type of ApoE allele, ApoE4 in your homozygote, your risk goes up many-fold compared to people who don't have this. It doesn't mean you'll ever get it, but it certainly is a higher risk. Uh, Having a first-degree relative with Alzheimer's diagnosis uh, puts you at higher risk, especially young onset, below 65. And then this is important. Vascular disease alone, diabetes, heart disease, hypertension, etc., vascular risk factors alone can increase the risk of Alzheimer's disease, obviously can increase the risk of vascular dementia, and also obviously could increase the risk of having them both at the same time. Now, there are early onset, young onset cases of Alzheimer's. They're very uncommon. Mendelian genes are present. I'm not going to go into that because it's so uncommon. It's really not relevant to the older population, but early onset people may have a Mendelian genetic problem that can be identified. So these are just some pictures. On the left is early changes, mild to moderate. You see the inner aspect of the temporal lobes are involved pathologically on a gross specimen that you see atrophy of the hippocampus. And eventually, with severe dementia, the whole brain is atrophied, the ventricles are enlarged, and the Alzheimer's pathology spreads throughout the brain. So how do these people present? How do they, when they come into clinic or seek medical care, how do they present? Well, commonly It's a spouse, adult child, or someone near to them that comes in with them and says their memory is bad. They're repeating themselves. They forget their keys all the time. They lose their wallet or purse. The patients sometimes lack a lot of insight into this. So it's important to get a history from a reliable observer if you can. So we already talked about short-term memory. Loss of orientation is an early symptom. People go on a vacation or a trip and they become somewhat disoriented uh, on the trip. The decline is smooth, usually slow over many years, without dramatic short-term fluctuations. If there's some rapid decline over weeks, you have to think that there's some other problem. And then other domains, as I mentioned, get involved beyond memory, language problems. The patients lose their ability to multitask. They lose their ability to operate the remote on the TV or use their cell phone and so forth. There's behavioral problems, as you all probably know. Depression and anxiety are extremely common, particularly early on, sometimes predate the onset of the memory trouble. Uh, they get patients later on get irritable, hostile. Some people just get apathetic. They can have delusions and hallucinations. Delusions about money issues are very common. Uh, Sleep-wake changes. Of course, sundowning occurs when people are hospitalized. That can certainly be a big problem. And the big problem in their management sometimes is they're very agitated and combative, which really can make the people with more advanced Alzheimer's, difficult to manage, as you know. So that in diagnosing this, the history is absolutely critical. As I said, you have to talk to a close informant. You have to ask about the rate of progression. You want to know if they've had sudden neurologic problems like weakness or loss of vision, something that might suggest a stroke or something else. You ask about all these things I just mentioned. Are they forgetting their keys? Are they forgetting to do things? Do they repeat themselves over and over? And does the problem now affect their ability to function at home or if they're still working? So the history is really absolutely vital. You want to know about their medical conditions, if they've had head injuries or other neurologic problems. Are they abusing drugs and alcohol? And I'll come back to this, but their medication list needs to be reviewed carefully. This is a busy slide. I'm sorry. I'm not going to go through all of this, but it's just basically saying you should rule out other medical illnesses, structural lesions in the brain. You should make sure you're not dealing with the acute problem, delirium or psychosis. We're going to review the meds, as I mentioned, and then you're left with a diagnosis of dementia. Uh, One of the types of dementia is most commonly Alzheimer's. So you do a quick neurologic exam, and they have an obvious hemiparesis or look Parkinsonian. And then cognitive screening is pretty important and it's somewhat cumbersome. I recognize that people don't have a lot of time to do this. Um, the two most common things that are done are the mini mental status exam, and I would say the most common these days is the MoCA, the Montreal Cognitive Assessment. I would point out there's this really quick screening test called the mini cog. You have them do a draw a clock test, which I'll show you in a minute, and then remember three words. And this is a pretty sensitive test. It's not very specific, but it can be done in just a couple of minutes in a busy clinic and maybe then prompt you to have the patient come back and do some more testing like a Montreal cognitive assessment. So remember the mini cog. This is the full Montreal cognitive assessment. It takes at least 10 to 15 minutes to do. Um, Again, the patient may have to come back. You don't have time to do that in a 20-minute visit. Uh, the other thing to consider is if you see a lot of elderly patients in your practice, maybe have someone in your clinic, a medical assistant, learn how to do this. And when I was in practice, we trained up the medical assistants. They liked doing it. They became very good at it, and it saves a lot of time. So that's a little hint you might consider. This is a draw clock test. As I mentioned, in the mini cog, it's also part of the full Montreal cognitive assessment. This is a very good test. It's very sensitive for cognitive impairment. You just draw a circle, put a dot in the middle, and then tell them to fill in the numbers, and then make the hands of the clock say 2:30. And you can see that even in fairly early Alzheimer's disease, things don't go well. People don't fill things in properly. They can't put the hands in the proper location. So as part of the mini cog, you have them remember the words and have them do this. And you can recognize if people are having cognitive impairment. So what's the differential diagnosis? You've diagnosed dementia. There's more than one domain involved. It's been slow. It's been gradually progressive. We look for structural brain disease. Most of the time, we don't find that. Uh, Things like subdural hematomas or a frontal meningioma, but we still look. Um, look more commonly if there's been a rapid decline, you're going to find structural brain disease. They're screened for thyroid disease, B12 deficiency, other things that can exacerbate or worsen early dementia are sleep apnea, severe depression, alcohol abuse, and then again, reviewing the med list. There's a bunch of meds that can exacerbate or worsen cognitive function in older people, and I've listed them here. Some of them are commonly used in under dopaminergics. There's metoclopramide that is can produce both Parkinsonism and cognitive decline if it's taken chronically in people who are sensitive to it. But old-fashioned tricyclics, oxybutynin for the bladder, other anticholinergics, benzodiazepines, opioids. Also, people end up on old-fashioned neuroleptics for sleep. Um, so reviewing the med list is really pretty important because you might be able to reverse some of the cognitive decline. There's no exact dementia panel right now. There is no blood test for dementia. I'll go into the blood tests that have recently come out for Alzheimer's later, but there really is no fixed testing. What's recommended is that when the typical patient with a typical history, older than 65, that you get a B12, a TSH, and a brain imaging study. CT is okay. MRI gives you a little more information. Now, neuropsych testing is a many hours of testing. It's tedious, it's expensive, it can be hard to get. It's not mandatory or absolutely or really necessary in the typical situation when you're screening instruments like Kamoka are abnormal, patients older, it's been a slow decline. You don't need formal neuropsych testing to diagnose dementia or diagnose Alzheimer's disease. There are a lot of other tests out there now. There's PET scans uh, that are really expensive, probably not covered by insurance, really don't need to be done in most cases. I'll talk about amyloid PET in a minute, but for the diagnosis, PET scans aren't needed. Now, if you're dealing with a 50-year-old previously high function person, um, somewhat rapid decline, obviously there's going to have to be a big workup, and that would include MRI, possibly an LP, uh, possibly other neuro tests, and neuropsych testing in that individual might be needed. So, you would definitely work up a younger onset patient more extensively. So why do we do this? They've got a degenerative dementia, Alzheimer's disease. Why do we even you just say, well, sorry, you've got memory troubles. That's common in older people. Well, it's really not normal in older people necessarily to develop dementia. There may be a treatable cause that you can find or something modifiable like the wrong meds, like thyroid deficiency, etc. Um, there are symptomatic treatments for Alzheimer's disease that have been around a long time. I'll go over those in a minute. Unfortunately, they don't help very much. There's also some new FDA-approved monoclonal antibody medications, and I'll talk about this extensively in a minute. But furthermore, the patients and the families want a diagnosis. They want to know what they're dealing with so they can plan for the future. They might want to get involved in clinical trials. There's a lot of those going on, and they might want to get involved in a support group. So there's lots of really good reasons to make an accurate diagnosis. What can be done to reduce the risk of Alzheimer's disease generally? Well, there's a lot of work that's been done in this area, and it's pretty clear that, first of all, a lot of people have mixed pathology, both small vessel disease in the brain, vascular disease. But even in those who don't, for some reason, managing cardiovascular risk factors can reduce the risk. So you all know about this. I don't need to talk about it in detail, but this is a very, very well established fact that working on cardiovascular risk factors can help reduce the risk of dementia. I'll show some data on that a little later. This study was looking for modifiable risk factors. It was a big meta-analysis just published. And they looked at 59 studies, and these are the factors that they identified in this study as reducing the risk of brain disease. Now, this is dementia and stroke and depression. So this is a little bit of a mixed bag, but I think it really applies to dementia for sure. And so moderating alcohol intake, cognitive activity is important, not just doing puzzles on the computer, but being engaged in social activities have been shown to reduce the risk of cognitive decline in older people. A Mediterranean diet, doing exercise, most of this stuff is pretty intuitive, but actually there's data that indicates that uh, these things can be modified and help reduce the risk of dementia as people age. This is a little chart here showing really what the impact can be on this. If you can manage vascular risk factors, avoid head trauma, uh, hearing loss is a big deal. You can't affect the patient's education, but social isolation can be modified. Air pollution, we really can't do much about unless you move to the country. Visual loss. So if you could modify all these things, you've reduced the risk of dementia by 45%. So the modifiable ones are a big chunk of this. Okay, so you've got treated, you've diagnosed someone with Alzheimer's disease. What can you offer them beyond a diagnosis? Well, these drugs, cholinesterase inhibitors, have been out for I don't know, a couple decades at least. They do not help memory, and I think you have to be clear from the onset with your patient and the family. This is not going to help their memory. It might improve their mood and behavior, make them more interactive, and they're well tolerated. Donepezil Aricept is the most common. It's generic and easy to use. It's worth a try, and it also may have a very small but real effect on affecting the progression of the disease, but that's somewhat debated. Later on, the other FDA-approved drug in later stage Alzheimer's is memantine. Um, Again, very modest effect, might make the patient calmer, easier to take care of. Again, review what other meds they're on that might be adding to the problem. And then there's certainly no reason not to treat depression and anxiety and sleep apnea if possible. All of these things can make Alzheimer's worse. So I just threw this slide in because it's common for people to ask about supplements, natural treatments, et cetera, et cetera. There's a lot of advertising on TV. And the Alzheimer's Association has this statement that there's really nothing out there to treat or cure Alzheimer's disease or help cognitive function, there's nothing to improve memory in terms of supplements. And I think this is a very definitive statement. Uh, there's probably no harm in taking Prevagen or some of these other supplements, but there's no data that they do any good. All right, I'm going to shift gears here, and we're going to talk about Alzheimer's disease and the amyloid hypothesis. I'm afraid we got to get into the weeds of this a bit for me to explain to you what these new drugs are about. And this amyloid hypothesis has been around for a long time. It's clear that in brains of people who have died and had Alzheimer's disease, you see this amyloid protein deposited. So here's a slide of a neuropathologic slide. Shows these globs of protein called amyloid. And then there's this other feature in these patients' brains called neurofibrillary tangles. This is basically a dead neuron, and the main constituent is a protein called tau, T-A-U, and we'll come back to this. So these are the two pathologic features of Alzheimer's disease. I mentioned PET scans. PET scans are excellent for determining if there's amyloid deposition in the brain. And you can see the normal on the left and the advanced on the right, and all the red that's in the brain of someone with Alzheimer's, advanced Alzheimer's, that's all amyloid deposition. So this is the hypothesis. There is a precursor protein. The amyloid precursor protein is a transmembrane protein which is normally present and has normal functions. And normally, part of it is cleaved off by an enzyme, and the amyloid beta, which is part of the part that's cleaved off, is degraded and removed. So it's not deposited in the brain. It shouldn't be deposited. So here's a little cartoon of the amyloid precursor protein that's transmembrane, and the enzymes cleave it. Part of that is beta amyloid, and that beta amyloid is normally removed. But for some reason, due to aging, clearly due to genetic conditions, amyloid deposition is seen, and it's not clear why this happens. No one really understands this. The amyloid that's not removed forms those plaques I showed you a minute ago. And the theory goes that these plaques are toxic and lead to neuronal death, brain atrophy, and clinical dementia. So the theory is that amyloid is the bad actor here in causing the disease. So again, here are the beta amyloid plaques that are the culprit, according to this theory. So in the past, there's been many drug trials, even vaccination trials to get amyloid out of the brain. They've really not been very, in fact, they've been negative in the past. Um, because the hypothesis is you get rid of the amyloid, you're going to stop the disease from getting worse, slow it down, it's going to be helpful. So the exact role of amyloid in Alzheimer's disease is still hotly debated, and it's not at all clear it's the primary uh, uh, pathologic process causing the neuronal death and the disease. It's hotly debated still. Nonetheless, there in recent years have been trials using monoclonal antibodies, which are used for many things, as you all know. And these monoclonal antibodies target amyloid and stimulate the immune system to remove the amyloid from the brain. As I mentioned, multiple previous trials have been negative, but in recent years, two trials were positive and showed some modest reduction in progression of clinical dementia. The most recent drug, donanemab, just got approved by the FDA less than a year ago, and it showed a 35% reduction in cognitive decline after 18 months in a particular group of Alzheimer's disease. I won't go into the details, but in one subgroup, the decline was reduced 35%. So after a year and a half, you're, in theory, not as bad as you would have been. So you have to get infused with these drugs. They're an infusion. The donanemab's once a month. They're very expensive. You need follow-up MRIs all the time. And then they have side effects. And these side effects are referred to as ARIA, amyloid-related imaging abnormalities. And this means either edema in the brain or hemorrhaging. So this MRI shows the white areas are actual edema as the immune system removes the amyloid. And the drugs have to be stopped if this gets bad. Sometimes it's mild, often it's mild, and the drugs can be either paused or not stopped at all. We don't have long-term data on the effects. We have 18-month data, maybe 3-year data preliminarily on these drugs. So we don't really know what the long-term benefit is yet. So what does this mean in the real world? Well, it's only an option for people with very early symptoms, either mild cognitive impairment or early dementia due to Alzheimer's. More advanced patients are not candidates for this. And there's many other exclusion criteria. The people with that ApoE4 allele homozygous, they can't have these drugs. The rate of hemorrhaging is way too high. And other medical comorbidities were the cause in the studies were patients with these were excluded. They were anticoagulated, for instance. And then there's logistical problems, multiple infusions, scans, getting insurance to pay for this. This is certainly being infused around the country now, but it's not a simple process. So these folks just published this. They have treated 234 patients over 14 months. 90% of them completed the treatment. 10% withdrew for various reasons. And their point was most of the time these infusions and treatment is can be accomplished. Now remember, these are highly selected patients. The ones with other problems, comorbidities, etc., were never started in the first place. The big problem is getting a patient, if they want this, to a place where the doctors are comfortable uh, providing the treatment. And memory clinics across the country now are swamped with referrals. So I mentioned this is still controversial. There are lots of other causes of Alzheimer's that are postulated. I won't go into this, but just remember that the amyloid hypothesis is still hotly debated. And there are people looking for other causes and other treatments very actively. So this was an interesting study just published that showed if you take a GLP-1 agonist, you're diabetic, and you're on it, your risk of dementia is actually reduced quite significantly. This is not clear why so much. This is dementia, all dementias, including Alzheimer's, vascular. But these drugs may be pretty effective in also reducing dementia risk. Something to think about. And this has generated a clinical trial, full-blown double-blind placebo trial in early Alzheimer's disease using semaglutide. And the results of this will be available probably in a year or two, I hear. And again, something to be aware of and to look out for. So I guess my point is these anti-amyloid treatments are out there. Uh, they probably aren't the final answer by any means, but there may be some patients who benefit and want to go through the rather arduous infusion schedules and follow-up MRIs, et cetera, and accept the risks of the treatment. So I want to talk very briefly about diagnosis. Biomarkers are a big deal everywhere in medicine now, as you know. And this was published last year about blood tests for Alzheimer's disease. And blood tests are a whole lot simpler than doing an LP, a lumbar puncture, and looking at spinal fluid, or doing an amyloid PET scan. So this study was done in Sweden. They looked at 1,200 patients with memory impairment. So these are symptomatic people. And they also used amyloid PET scanning as the gold standard and cognitive testing to be sure they were dealing with Alzheimer's type dementia. Turns out the blood tests for beta amyloid and also that other protein tau that I mentioned, the dead neuron protein, are about 91% accurate compared to PET scanning. Very, very good result as far as the blood testing. Now, FDA approval is pending, I understand, for these tests. There are some methodologic issues. Insurance coverage may not be out there yet for these blood tests. And at this point, I would recommend you not order them because there are some pitfalls. I certainly wouldn't order them in the patient that comes in and says, well, my brother has Alzheimer's. I want to know if I have it, but I don't have any symptoms. I don't think you should order it in that patient. The tests may come back positive, but that patient may never develop Alzheimer's disease. So we still have to figure out what the proper approach will be with these blood tests, which are definitely going to become used in a widespread manner. I still think a clinical diagnosis is going to be very important, but it might be helpful eventually just to do a blood test instead of uh, uh, more extensive testing like a PET scan or a lumbar puncture. And someday, who knows, we may be screening people with these blood tests like we screen people's cholesterol. I don't know. That's a ways off, but something to think about. Okay, that's all I had to say formally. We have time for questions. I'd be happy to take any questions that you have.
All right. Thank you, Dr. Mesher. So we do have a few questions. I'm gonna go ahead and go through them. The first question is, in what cases should we refer someone for genetic testing for APOE?
That's a great question. I think the main use of that should be in the patients who are considering the anti-amyloid treatment. Because even if you're homozygous for the ApoE4 allele, you still may never develop Alzheimer's disease. You may die at age 85 of some other reason. So it doesn't really, I don't think it really helps. Yes, you could say, oh, you're more at risk, but from a practical standpoint, I don't see how that helps the patient. So I think in the setting of the anti-amyloid treatments, it's absolutely necessary to do it ahead of time. But in the routine diagnosis of Alzheimer's disease, I'm not sure there's a major place for it at this time.
The next question, it says, if a patient presents stating they are worried about their own memory problems, does that alone make dementia unlikely since they should lack insight?
That's a great question. I think the rule of thumb is when the patient comes in uh, saying their memory is poor, you probably don't have to worry too much. And when the family member brings them in, it's the opposite. I wouldn't say that everybody lacks insight. I think some highly functioning person uh, very early on could recognize it. And so I don't think that's a hard and fast rule. Of course, there are very few hard and fast clinical rules in medicine anyway. So I guess it would depend on the patient. And, what you can do is have them come back, do a MOCA test. If they score very well, you can reassure them. Um, if they're really worried, they can have neuropsych testing, and that's the gold standard, and that would show whether there's really any memory trouble or not.
All right, there's two more questions, or a few more questions are starting to populate, but let me ask this one before I ask the longer one. Can any criteria at diagnosis predict a rate of cognitive decline?
I don't think so. I don't think so. And for some reason, people decline differently, at different rates, I should say. So I'm not aware of any testing that can predict that. No.
Okay. This one's more of a diagnostic question. It says for diagnosis, basically informant confirms declined. Decline is in more than one memory domain. They have a decline in function as well. You've done mini COG and ADL/IADL screening, maybe. You've ruled out other medical causes. You mentioned including labs and med review, no red flags on exam, and the pattern of memory loss matches Alzheimer's in its typical course. We can go ahead and diagnose and treat, or we need the CT to rule out the structural brain lesions first. I work in an uninsured setting and getting tests or specialty visits are very tough.
Um, yeah, that's a great question. The you know, standard is to get a minimum of a non-contrast CT. Um, I think if you're in that setting and everything really fits, patients older than 65, uh, you do a neurologic exam, they have no focal findings or anything to suggest any other problem. It's been a slow decline. The problem presented with short-term memory problems, and then it's evolved into language, visual, spatial, executive. It's all typical. you're probably in pretty firm ground. The odds of you finding something else on a scan are very low. Not zero, but pretty low in my experience for sure. I ordered many scans in this setting, and you just don't turn up much in the very typical presenting set of symptoms. So I hope that answered your question.
Mm. And she said, yes, it does. Thank you. Okay, and then it looks like one of the last questions we have, it says, can you speak about differentiating early dementia from depression?
Yes, I think that can be hard. I think that, you could, if you do a depression scale and it's really abnormal and you do a MoCA and it's normal or almost normal, um, I think you're dealing with depression. Can you sort this out further? Sure, you can do neuropsych testing and that would completely sort it out, I think, in most instances. So if it's available and the patient has insurance and you feel the need to really do that, you could do that. Alternative approach if would be to treat the depression if it hasn't been. Obviously, not everybody responds to one or two or three trials of antidepressants, but you could try that. Um, but I think using the MoCA and using a depression scale probably would help.
Mhm. All right. Are there any other questions for Dr. Mesher? And while we're waiting on that, I did drop some reminders in the chat. Reminder that the CME survey is going to appear in a tab when you close out of this webinar. We do appreciate the feedback that is provided. And we hope you've enjoyed today's session. This was recorded and it will be available for viewing within a few weeks on our community portal under the demand library. But any other questions for Dr. Mesher today? I'll give it a minute or two just in case somebody's typing. Oh, it looks like we do have somebody that wants to um, come on and talk. So 1 second here. Okay, go ahead. You should be able to unmute now.
Hi, thank you. Very wonderful presentation. I'm just curious, oftentimes with older people with or without dementia, they advise against moving to a new environment late in life. What are your thoughts about staying in a environment that the person, someone with Alzheimer's, is used to and comfortable with versus moving to an environment where there maybe is more social interaction or more stimulation?
Well, that's a really good question. I wish I had a really good answer for that. It is kind of trying to weigh the pros and cons. I'm kind of reflecting on my own personal experiences with family members and people I know. And I think the social interaction part that I was speaking about today is really more in terms of preserving cognitive function in older folks. And so I, this is just my opinion. I don't have a lot of data to back this up. I think if people can be kept in a familiar environment, it's doable. There's people that can take care of them without being overwhelmed. I think that's probably best. I think the advantage of social interaction is probably kind of lost from the mid stages on um, of the disease. But frankly, this is just an opinion.
Thank you.
Thank you. Okay, I'm gonna go ahead and move. Does anyone else have any questions for Dr. Musher? I'll give it one more minute. If not, we will close today's session.
Well, thanks everybody for attending.
Thank you, everyone. Have a great rest of your day. Bye, everyone.